Welcome to the Cyflix Grief tapes about therapy for traumatic grief. My name is Geert Smid. I'm a psychiatrist and endowed professor on psychotrauma, loss and grief. I work at ARC National Psychotrauma Center and the University of Humanistic Studies in Utrecht, the Netherlands. This training focuses on recognizing and treating traumatic grief following the loss of a loved one, often under traumatic circumstances. Recognizing traumatic grief is important because it may cause intense suffering and impairment, and therapy for traumatic grief may lead to large symptom reductions. Therapy for traumatic grief entails a confrontation with both the reality and the irreversibility of the loss and details of traumatic images or memories surrounding the loss. It provides much room for exploring what the loss means for the bereaved persons and their view on themselves, the world, the future, and their relationship with the deceased. A special aspect of therapy for traumatic grief is that most therapists have themselves experienced loss. Good self-care and awareness of one's own sensitivities are therefore crucial. We hope that you will appreciate completing this training. Therapy for traumatic grief is also termed traumatic grief-focused cognitive behavioral therapy or brief eclectic psychotherapy for traumatic grief. In recognition of grief's capacity to cause long-term, severe and incapacitating suffering, grief disorder diagnoses have been included in international diagnostic systems. In 2013, DSM-5 included persistent complex bereavement disorder, or PCBD. In 2018, ICD-11, and in 2022, DSM-5 text revision included prolonged grief disorder, PGD, replacing PCBD. Grief always implies longing and yearning or preoccupation with a deceased loved one. These core symptoms of grief are therefore highlighted here. All grief reactions shown here may turn into symptoms of grief disorder if they are prolonged and cause suffering or impairment. More about this is in the next slide. The 2 core and 8 additional symptoms that you see here are in accordance with DSM-5-TR. In italics are wordings that are specific to ICD-11. When does grief become a disorder? This depends on impairment and suffering, duration, cultural aspects, and number of symptoms. Please note that ICD-11 criteria are more lenient than DSM-5-TR criteria for PGD. So for a patient, it's somewhat more likely to fulfill ICD-11 criteria for PGD than DSM-5-TR criteria. Traumatic grief may be thought of as a combination of separation distress related to the death and traumatic distress related to the circumstances of the death. Separation distress and traumatic distress interact, causing people to fear their own emotional reactions. Involved neurobiological systems include the neural reward system in separation distress and the neuroendocrine and neuroinflammatory stress systems involved in traumatic distress. In traumatic grief, symptoms of PTSD and depression often occur. Apart from a diagnosis of PGD, diagnosis of PTSD and depression need to be considered. The TGI-SR Plus is a validated measure of DSM-5-TR and ICD-11 PGD and DSM-5 PCBD. Translations are freely available online in multiple languages. The questionnaire can also be used in populations exposed to multiple loss, such as refugees. How do symptoms of PGD, PTSD and depression develop over time? Malaysia Airways Flight 17, flying from Amsterdam to Kuala Lumpur, was shot down while flying over eastern Ukraine in 2014, killing 298. Of bereaved relatives, about 170 filled out questionnaires from 8 months up to 42 months following their loss. And here you see different symptom trajectories over time. Chronic symptoms of PGD were present in 18% of the sample, PTSD in 10% and depression in 6%. Recovery occurred in 4% from PTSD and from depression in 8%. What do we know about predictive associations of symptoms over time? Following bereavement, grief symptom levels predict PTSD symptom levels, but not vice versa. What do we know about predictive associations between symptom levels over time? Following bereavement, grief symptom levels predict later PTSD symptom levels, but not vice versa. This was found in the MH17 disaster bereaved sample, as well as in 2 other studies. Importantly, these findings contradict the notion that PTSD should always be treated first before addressing grief. Importantly, these findings contradict the commonly held notion that PTSD symptoms should be addressed before grief in treatment. Therapy for traumatic grief addresses both PGD and PTSD symptoms simultaneously. Risk of PGD is related to different factors, including circumstances of the death, the relationship with the deceased, social, cultural, and individual factors. Please note the strongly increased risk of PGD following loss due to traumatic or unnatural causes of death, compared with natural causes of death. Risk factors are related to the separation of the loved one, traumatic distress surrounding the death, and events after the loss, specifically following traumatic loss. The interaction between these effects on mental health produces the syndrome of traumatic grief. The following figure shows how meaning attribution following loss is related to 17 determinants of meaning attribution that can be grouped into 5 categories that we already saw when discussing the risk factors. Determinants of meaning attribution are event-related, relational, that is, with the deceased, individual, social, and cultural. Groups of determinants may be overlapping. For example, cultural determinants of meaning attribution include the explanatory model, religion or spirituality, healthcare and spiritual care, and rituals. Rituals may also determine meaning attribution to the relationship with the deceased. A cognitive behavioral rationale for therapy for traumatic grief is presented here. Grief is maintained by three factors, including insufficient integration of the loss, negative appraisals, and avoidance behaviors. Interventions are therefore focused on confronting the reality of the loss, modifying negative cognitions, and reducing avoidance. These include different forms of exposure, writing assignments, cognitive restructuring and meaning attribution, activation, and rituals. Therapy for traumatic grief integrates evidence-based interventions for PGD, PTSD, and depression. It consists of about 16 sessions shown in the figure to the right. Therapist actions include providing information, involving significant others, listening to the story of the loss and the lost person, providing space for emotions, supporting cognitive change and meaning attribution, and stimulating activation, restoration, and future orientation. Oh yeah. Grief-focused exposure comprises 4 modules. Imaginal exposure involves the story of the death, aimed at reducing avoidance of specific memories. General exposure involves the relationship with the deceased, aimed at accepting the reality of the loss and tolerating feelings of sadness. Stimulus exposure involves bringing objects, such as pictures, or visiting meaningful places related to the deceased, such as the grave or the place of calamity, to reduce phobic avoidance. Revising grieving behavior involves diminishing behaviors to keep the deceased symbolically alive and reducing compulsive proximity seeking. Finding meaning relates to evaluating implications of the loss. How does the death of the loved one affect the bereaved person's view on him or herself, others, the future, and the relationship with the deceased? The therapist aims to foster the patient's self-compassion, acceptance of emotions, re-engagement with people and activities, and a revised connection with the deceased. Revising the connection with the deceased can be achieved through symbolic interactions with the deceased. These include different writing assignments, for example, an ongoing farewell letter to the deceased, imaginary conversations with the deceased, and culturally appropriate rituals. The Bereavement and Grief Cultural Formulation interview explores cultural traditions related to death, bereavement, and mourning. Cultural meaning of encounters with the deceased, such as in dreams, and help-seeking and coping. The BGCFI supports culturally sensitive diagnosis, treatment negotiation, and treatment.